So this morning I will be talking about, I'll do a brief review of part one if you happen to not be here during part one, and then I'll talk about what are the challenges we face with treating metastases, how research and medicine, so I think it's nice to have both myself and Dr. Kaur here and really representing the sides of research and medicine and how those fit together, and then talk about preclinical research. And I know, as Rachel said, we'll have time for questions at the end. And so just to give a quick overview, what is metastasis? We talk about, we hear words like metastasis, metastasize, metastatic. And it is the development of a secondary tumor at a distant site away from the primary site of cancer or the primary tumor. And we can also use it to describe an action or process of how cells spread through the body. And so in this figure, hopefully what you can see is this is a breast tumor or breast cancer or the primary tumor. And these areas are, or these arrows are showing potential spread or metastasis of those tumor cells. And hopefully what you can see is that these are different ways in which tumor cells can either spread or metastasize to other parts of the body. And so let's review part one. We talked about that cancer develops in stages. It doesn't happen overnight. We also talked about that cells really like to move. And so they like to move towards things and they like to move through things. So really these two things together make up the metastatic process in which a tumor cells can go into the bloodstream, travel through the bloodstream and sort of pop out at a different site and begin to form a new tumor, which is termed a metastasis. We understand that cancer or metastasis is a very complicated process, but it's often not random. And so we use this analogy of both the seed and the soil have to sort of be compatible and work together to get a plant to grow. The same way a tumor cell and where it's actually going to land and grow is important. If those two things can't work together, then you're actually not going to get a metastasis to grow. And then we left off on that there are ways both with cells and with often mice models that we can actually study metastases in the lab and try to understand it better for hopefully getting better treatments for cancer patients. And so what are some challenges in treating metastatic cancer? So one thing is that metastatic tumors are not always responsive to therapy. As I said, metastatic tumors can grow in different organs or different soils than the primary tumor. So you can imagine if you have a metastasis that grows in the lung versus in the brain, how those two metastases respond to the same treatment is going to be different. And then we know primary and metastatic tumors, even from the same patient, can actually be quite different. So these are two fruit, but we also know that apples and oranges are very different. And so this sometimes poses a lot of challenges and makes it seem like it's an uphill battle. But I would hope that on the research end, we're really trying to gain ground. And so how do we do that? And so how do we begin to overcome these challenges? And I think this is where research comes in. There's a partnership between medicine and research. And I like this sort of graphic because each of the hands are puzzle pieces. So there's many parts of medicine and many parts of research that really need to work together to sort of overcome these challenges. And so it's the partnership between research and medicine that really holds promise for new breakthroughs. And so how do scientific researchers like myself work with doctors like Dr. Kaur to really address these challenges? So let's give some those same examples of treatment challenges. So metastases don't respond to current therapies. Well, as researchers, we can begin to identify new drugs that are very specific to metastases. Metastases grow in different soils that change how they respond to therapy. So we can try to understand each of those soils and understand why metastases grow there. And then primary tumors and metastases can be very, very different. And so as a researcher, we can try to create better tools that are specifically to model metastases, not just sort of cancer in general, but really specific to metastases. And so our hope is that we can sort of help with research to kind of overcome or fill these gaps. So on one side, if you have the challenges we face, and on the other side, we have improved treatments for patients, what sort of is what we're hoping to fill that gap is preclinical research. So what is preclinical research? And it's really defined by three things. The first is that it uses cell and animal models. And in cancer biology, sort of our model of choice is often the mouse. The second thing is it's done before any human trials or any research is done on humans. We're doing it first in cell lines and animals. And it's really to assess safety and toxicity and figure out what's the best starting dose for when we start in human studies. And so how do we make preclinical research more applicable? So if we have preclinical, or also termed basic research, on one end with cells and animals, as I said, and on the other hand, we have clinical research or clinical trials in humans. So our hope is that we would have treatments and drugs that would make it from preclinical research all the way to clinical trials. That would be the ideal. But in fact, what we often see is that there are a lot of drugs and compounds and treatments that usually end up being trash. They might work well as a preclinical study, but when it comes into the clinical trials, they don't work. And so we try to find new ways to fill these gaps. And so I think the bridge to help kind of get drugs from one end all the way to the other is something called translational research. So what is translational research? So really the easiest definition is it's lab research that is truly patient-centered. So it's from the patient and it's for the patient. So an example of this is if you have cancer patients, what we can do is we can take their tumor. So if they have, let's say, a surgical resection of either a breast tumor or a brain tumor, we can actually get, as researchers, pieces of that tumor, and we can take it to the lab and we can begin to create things in the lab, such as a patient-derived cell line. So meaning that this cell line is actually derived or created from a patient. It's specific to that patient. We can also make patient-derived xenografts. So xenografts is a sort of fancy word if you think graft, like tissue. So we can take the tissue from that tumor and put it into the mouse and then try to study it. Or we can do something called genomics, where we study the DNA. So take sort of a magnifying glass to the actual tumor cells and say, what's changing, what's going on? And so our hope is by doing these different studies with tissue or with things from actual patients that have cancer or have metastases, our hope is that we can create better treatments and have less treatments that sort of end up in that garbage can. And so there's another term that you might often hear a lot called bench to bedside and back. So that's another sort of fancy way to say translational research. And so I think this picture kind of shows it well, where you have basic science research on one side and the clinical setting on the other side. And so research findings are applied to the clinic. And then issues that are found in the clinic or during clinical trials are then go back and are studied in the lab. And so this is actually done over and over in a repetitive process until we can really achieve optimal benefits for cancer patients. And so I'd like to give an example of translational research. And so of course I'm a little bit biased. This is the lab that I get to work in. So this is Dr. Melanie Hayden Gephart, and I feel like she really embodies what translational research is, because she's both a scientist and she's also a clinician. And so she sees patients and she also does science. And so our lab is really focused on understanding brain tumors as well as brain metastases. And so sort of an example of this is looking at a drug that I'll just term QBS. And so we really wanted to understand, could it be helpful in treating metastasis? So when we talk about translational or preclinical research, there's lots of steps, and we'll sort of walk through each one of them. So the first step when we think about preclinical research is, do we have a model? So a big problem with cancer research is that in the past, we have models, for example, mice, that work really well in the lab, but they don't actually model the human disease. And so you can imagine, if things aren't modeled correctly, when we try to take that drug from a mouse into a human, it doesn't work. And so a big push in sort of the research field has been to update our models so that they actually match what we're seeing in patients that have that disease. So here is an image of, you can see at the top, a human brain, and then also in the bottom image, a spinal cord. And it's a little bit hard to see, but what the red arrows are pointing at are actually tumor cells. So there's a very specific type of brain metastases that sort of lines the inner layers of the brain, as well as on the spinal cord. And so our lab has a very specific model in which a mouse model, which we see that exact same thing. And so what I hope you can see is that here are cancer cells, both in the mouse brain, as well as in the mouse spinal cord. So that's sort of our first check mark. We actually have a model that we can use that will tell us something about the human disease. So when we actually use this model to treat drugs, it'll be more applicable to patients. The second step is cells. So when we have cancer cells in a petri dish, we can treat them with QBS. And our hope is that those cancer cells are going to die. And that's in fact what we did see, those more cells die. And then when we treat with more and more QBS, we get even greater cell death, which is our hope. The more drug you put on those cells, the more they're going to die. So that gives us sort of a check mark. It works in cells. And then we go ahead and we take it into mice. So we can have two mice or two groups of mice, and we can implant tumors into their brains. And then in one group, you're going to have sort of a placebo drug. And in the other group, we would have QBS. And so what we found is that in the placebo group, those mice, their brain tumors kept growing. While in the QBS group, we had very, very little or very slowed growth of those tumors. So that sort of gives us a check mark there. And then we also, and just as a note, everything that we do with our mice is humane with lots of thought and care. And there's lots of rules and regulations around animal studies and research. So then we want to think about safety. So a big thing when we work, especially in terms of the brain, and I think Dr. Kaur can speak a lot to this, is that we want to think about not harming the normal brain. We want to get that cancer or get that tumor without messing too much with your normal brain. So we think a lot about safety. So this is an image of where we stain for something called LAT1, and this is the normal brain. And here's a brain metastases. And now without understanding anything at all about LAT1, you could probably figure out one major thing. There is a lot more LAT1 in the brain metastases than in the normal brain. So you see a lot more pink staining in brain mets versus in the normal brain. And so why do we care about LAT1? So actually, if you have a cell, what we think is that LAT1 is almost like a transporter or a tube that sits on the outside of that cell. And it helps move that QBS drug from the outside to the inside of that cell. And so then QBS collects, or that drug collects in that cell, and then it leads to cell death. And so why is this important? So when you have the normal brain, there are very few LAT1 transporters, or those tubes on the outside of normal brain cells. And so you get very little QBS or very little drug into normal brain cells. While in brain metastases, as we saw in the picture, a lot of brain tumor cells have lots and lots and lots of LAT1 on the outside. So what we think is happening is a lot of that drug is able to collect and congregate into those cells, which eventually causes those cells to die. And so that sort of check marks what we would like. It's not affecting normal brain cells, but it is attacking the tumor and causing those tumor cells to die. And then we go into clinical trials. And so we have potential clinical trials for this specific drug. So this is the point when it's sort of translated, where we get that word translational research, translated to the patients. And then the last step is really we take it back to the lab. So if we have patients that went through that QBS clinical trial, what we can do is we can get pieces of their either tumor or even samples of their blood, and we take it back to the lab and we begin to study it. We can make cell lines, we can study the DNA and try to really understand why patients either responded or maybe why patients didn't respond. And this helps lead to better treatment, which then gets in turn circulated back to clinical trials and back to patients. So really it's sort of this iterative process or repetitive process that goes around and around and around until we can arrive at a drug or a treatment that works really well. And so let's do a quick brief review. So we know that there are many challenges in treating cancer metastases. It often can feel like an uphill battle, but really it's the partnership between research and medicine that we think will bring the most new and exciting breakthroughs. And preclinical research involves cells, animals, and even patients when we talk about translational research. And there are many steps of preclinical and translational research, but the end goal is to be able to take what we know and what we've shown in the lab and translate that over to patients for their benefit, and working with doctors to make that happen. And so thank you to my mentors, to Dr. Kaur, as well as the Stanford Science Café team, and for all of the patient advocates and their families for being here.
All right, so thank you so much again for joining us for the second part in the series of talks to discuss brain metastases and how we can understand it better. I will be primarily focusing on the clinical aspect of things. So the objective of our talk today, I will be covering preventative measures. Basically, the point is to understand what it means to for there to be a preventative measure, and what screening tools do we have in the oncology world for the preventative measures. Followed by this, we'll talk about treatment options. Generally, a word that gets thrown around a lot is standard of care. What does it mean to have standard of care? What treatments entail standard of care? followed by clinical trials to discuss what options there are outside of standard of care for patients if they choose to further pursue them. So the aim of preventative medicine basically is to prevent the occurrence of a disease and halting a disease and averting resulting complication after its onset. So that is primarily the focus of preventative medicine. And this can generally be practiced by governmental agencies or physicians. And when I say governmental agencies, I think we're in a prime example of the COVID vaccine right now, which is being mandated by governmental agencies to prevent, spread of this disease further. So this is basically preventative medicine. How does it relate to the oncology world? So in the oncology world, we have what we call cancer screening. And there's very specific guidelines in terms of when certain cancers should be screened for. So at a very early age, we start talking about certain types of cancers. Around 21 years of age, in females, we start talking about screening for cervical cancer. Around 40 years of age, we start talking about screening for breast cancer, also in females. Around 45 years of age, you will notice that your primary care physician may start talking to you about colon cancer screening. And around 50 years of age is when it's recommended, at least definitely by 50 years of age, for females to start getting screened for breast cancer with mammograms if they haven't started already. And around 65 years of age is when you start having discussions to stop the screening process. Now, is there routine screening in brain cancer? The question is a little complex. Yes and no. So the first point is that brain cancer is rare. It is not as common as some of the other cancers that get screened for. Therefore, routine screening for brain cancer is not done. However, if the patient has a certain type of cancer, and within that type of cancer, they have a certain type of subtype, we might consider screening them as a preventative measure because we know that subtype has a propensity to go to the brain. For example, if you were part of if you were able to join us for the first series of our talks, I give an example of having a VIP ticket to get into, Disney World. If you have a VIP ticket to get into Disney World, then you'll be able to get cut in front of the line and go in without any issues. Similarly, certain subtypes of cancers have certain molecules on them, and those molecules allow them to bypass into the brain without any issues. So we know those cancers can get into the brain without a problem. And those cancers we should be screening for to make sure that there's no lesions that are forming in the brain. Most of the time, the screening will occur after the metastasis has already occurred. So the patient may present with symptoms and we might screen them and find that there is a tumor. Once that patient gets treated for that tumor or the lesion in the brain, thereafter, they will continue to get monitored to make sure that there's no other lesions popping up. Because at that point, we know the cancer has learned to get into the brain. So within each category of cancer, lung cancer, breast cancer, melanoma, there are many, many subcategories. And these subcategories are basically identified by the molecules that are presented, very similar to the tickets, by the cancer to get into the brain, which allows us to understand if this type of cancer will get into the brain or not, and should we be screening for them. All right, so moving on to treatment. So let's talk about standard of care. So what does standard of care mean? It's also known as best practice, standard medical care, and standard therapy. And this is basically accepted by medical experts as well as others in the field as the most proper treatment. This is usually evidence-based medicine that we're practicing and is the most widely used. Another word or another terminology that gets thrown around is adjuvant therapy. Adjuvant therapy, also known as adjunct therapy or adjuvant care, is therapy that is given in addition to the primary or initial therapy to maximize its effectiveness. And lastly, another terminology that comes up a lot is neoadjuvant therapy. So neoadjuvant therapy is basically therapy that's given prior to the standard of care. Um, and this is mainly given for the standard of care to work well. So an example that I gave here is hormone therapy that's given in patients who may have breast cancer to kind of shrink the tumor for make it easy for the surgeon to go in and resect it. All right, so before we get further into treatment, let's talk about treatment history and how far we've come in oncology. So way back in the 1800s, the initial approach for any tumor growth was primarily surgery. They would go in and take out the tumor and hope that there was no spread and it doesn't come back. Of course, there are many limitations to surgery. A lot of the tumors were inaccessible or they had already spread by then, which basically led them to be terminal cancer at that point. The next step that we took in terms of advancement of oncology was radiation. So in early 1900s, X-rays or radioactive isotopes were starting to get used to kill cancerous cells. Of course, there are many limitations of this as well, and potentially, severe side effects to the organs around the radiation. Then came chemotherapy, which we're all well versed in. This came around late 1940s, and this is basically therapy that was developed to go in and damage the DNA of cells, leading them to die basically and not replicate. While the DNA of the cancer cell does get affected, it also affects the DNA of healthy cells around the cancer, which can lead to severe toxicities in many patients and not well tolerated in a lot of cases. Then we move forward to targeted drugs. So targeted drugs are basically referred to more gene-based therapy where certain molecules that were like those same VIP tickets, if the cancer has certain type of target, we are able to provide them with a drug that may target that specific molecule. And the hope is that it will then prevent the cancer growth. There's very many limitations to this. Many cancers don't have targets, and even the ones that do have targets, the drug may not work on them for other reasons. Cancer is, unfortunately, they tend to learn and evolve very quickly. So that really interferes with a lot of the therapies that we have, leading to basically resilience of these cancers. And now the most recent, and I'm sure you've heard of cancer therapies, is immunotherapies. So this is basically supporting the immune system to allow to recognize and eliminate tumor cancerous cells. There are many subcategories of immunotherapies. I will touch on it broadly because there has already been a really great discussion in Science Cafe about immunotherapies, but I will briefly touch on it to explain a little bit more in depth what it means. So that was the cancer history and how far we've come. So before we jump into further treatments, we have to talk about who is providing the care. So initially, when a patient usually presents with symptoms, the first thing that gets done is imaging. They get an MRI or a CAT scan to see what is causing these symptoms. The imaging is read by a radiologist. Radiologists would look at the MRI CAT scan and say, hey, this is what I think is wrong, and will pass that information over to an oncologist. Generally medical oncologists. There are subcategories of medical oncologists who are subspecialized in each field. The medical oncologist will come to a preemptive diagnosis and will then further discuss it with a surgical oncologist who will then go in and take a biopsy. Once the biopsy is taken, that is reviewed by a pathologist who will look at it under the microscope and tell us, hey, this is what the cells look like. I think it's this type of a cancer. That information then gets passed back to the medical oncologist, and this whole team then comes together in addition with the addition of a radiation oncologist to come up with the best plan for the patient to treat that cancer. So as you can tell, many moving pieces, many specialties working together. So one of the times that we do come together in the same room is what we call tumor board. I wanted to bring this up because many times patients will ask me, well, this is a difficult case. Can we discuss it with this person? And I want to let them know, generally at many, many big academic centers, we have what we call tumor board, where all the experts come together in a room and we discuss each patient's generally difficult case in great detail to come up with the best treatment option. And it's made up with medical oncologists, radiation oncologists, surgeons, and others in the field who will provide us, who can give great input. Others on the team that we should highlight are pain management and palliative care. The reason I want to point out palliative care here is because many times when we think of palliative care, we think of hospice. That is not the role of palliative care solely. Hospice is a very small component of what palliative care does. Their main piece is one, symptom management. We refer to palliative care because they're subspecialized to making sure the patient is comfortable and they're enjoying their best quality of life. What they will do is, in addition to controlling pain, they can control fatigue, they can control constipation, diarrhea, or any other symptoms that are just making the patient not enjoying life as much as they should be or can be. In addition to this, talking about decision making. Hey, should I go forth with this treatment option? Advanced directives, goals of care, and other communication topics that may come up. So that's the team. So what's the first step in terms of treatment? We generally, it's surgery. It may not always be because every cancer is so different, but generally we start with surgery. So here we have a piece of cake, and that whipped cream with the cherry on top, assume that to be a tumor. So in brain cancer, we have two options. The first is gross total resection. So if you enjoy your piece of chocolate cake without the whipped cream and without the cherry, and if somebody has placed that on your cake and you ask them to fully remove it, we call that gross total resection. And in medical terminology, we would say that the cancer has fully gone, it's been taken out, gross total resection. We don't see any obvious cancer cells. Of course, there can be microscopic components of cancer that may still be lingering that can cause it to come back, but usually to the naked eye, we don't see any obvious signs of the cancer left behind. And the other component of this is subtotal resection. So subtotal resection is you have your whipped cream, you have your cherry, the surgeon goes in and does the best possible job they could, but there is still a little bit of cancer still hanging around. So the whipped cream in this case was removed, but the cherry is still sticking around. So we know in that case, the cancer growth can certainly reoccur. Why is this important? Because in many cases, once there's a gross total resection, it may not need to be followed up with other types of treatments, such as chemotherapy or radiation. But many, many times, if there's a subtotal resection, we usually do have to follow it up with some other treatment because the chance of that cancer further growing is much higher. So what therapies do we follow it up with? And these may sound familiar. There's chemotherapy, there's targeted therapy, and then there's option of immunotherapy. So chemotherapy, like we previously touched on, is basically generally targets the DNA. The DNA of the cells is basically injured, preventing the cell from replicating. Not only are you injuring the DNA of the cancer cell, you also injure the DNA of other rapidly dividing cells, which leads to many, many side effects, and it's usually not favored. And over time, cancer cells, because they're smart, they tend to build resistance to chemotherapy. That's why we always have to keep jumping from one option to the next. The next is targeted therapy. Again, targeted therapy is basically targeting a certain protein that the cell is expressing. For example, in breast cancer, there's HER2, and we have therapies against HER2 that we will give. Again, it does not come without side effects, and it also does not come without resistance. In addition to this, not every cancer will have targets, and even if they do, there's no guarantee that acting on those targets will stop or slow the growth of this cancer from growing. And lastly, we have immunotherapy, which is basically using the patient's own immune system to go ahead and fight against the cancer. The side effects of immunotherapy also can be very severe and generally present as an autoimmune process where the therapy that's given to target the cancer also starts attacking the person's own body. All right, so I will give one example of what does it mean to have immunotherapy, or how does it work? So there are a lot of moving pieces in immunotherapy, but generally the first, one of the ways is basically to correct the immunological problems that may have occurred to facilitate the growth of cancer cells. Another piece may be enhancing the immune-mediated destruction of cancer cells. Weakening the cancer cell's ability to evade the immune system is another way of us using immunotherapy. And lastly, targeting certain markers on the cancer cells to specifically prevent their growth. So here we have an example of what we call a checkpoint inhibitor. It's basically over time, the tumor itself has learned to turn off the immune response. So on the left-hand side, you will see the tumor cells. It's plugging right into a receptor and lighting it up as red, turning off that immune cell. So the immune cell does not recognize a tumor cell as foreign and does not destroy it. So what we have been able to do is basically go in and prevent the tumor from attaching to that receptor, allowing the immune cell to continue to stay on, which will now allow the immune system to continue to go around and recognize these tumor cells as foreign and hopefully destroying them and preventing their further progression and growth. All right, so does all this work in the brain? Well, it's a little complex. So if you may recall from my previous talk, we spent a little bit of time talking about the blood-brain barrier. So the brain works primarily as a gated community where the cancer can thrive and not allow penetration of treatments because of the blood-brain barrier. The barrier is like the gatekeeper. And it allows very minimal things to pass through, and rightfully so, because the brain is considered a coveted organ. Only about 98%, I apologize, 98% of drugs generally do not get in. 2% of drugs generally tend to get in, and even those are certain types that are what we call lipophilic type of drugs. And this is another reason why it's so difficult for us to control cancer once it's gone to the brain. So what does it mean? We have the blood that is the component that has usually the drug in it. We have the brain, and in between we have what we call these tight junctions that do not allow the penetration past the blood into the brain by this gatekeeper now that we have as the tight junctions generally in between. We have slowly learned to overcome this. This is still in very much clinical phase, but we're trying to make some room for chemotherapy in this realm of the blood-brain barrier. There's new treatments coming out that we can use with chemotherapies called ultrasound-based. So what it does is basically the patient is injected with small microbubbles, and then an ultrasound emitter is placed. The wave of the sound wave with the microbubbles basically tends to break up that blood-brain barrier and allow for penetration, or these microbubbles then to pass through into the brain tissue, which overcomes this issue of the blood-brain barrier being so specific about what it lets through. The good thing about this is that it can self-repair. So once we have used it in that time period and allowed that chemotherapy to go through, the blood-brain barrier will repair itself. However, it is still in very much in infancy, and it has not yet become a standard of care. We're keeping our fingers crossed that this will come through to much sooner. So just to review again, why is there an issue to control cancer in the brain? Well, we just talked about the blood-brain barrier. It doesn't allow for penetration. And second is, not all treatments are made equal. With that being said, the treatments that work in the body may not work in the brain because the properties of the cancer and the treatments have to match. Those, like we said, the markers have to be there for it to, one, get into the brain, and the properties of the cancer and the treatment for the targeted therapy to match. Similarly, you cannot eat a spoon with a fork. You need a soup with a fork. You need a spoon to to enjoy your soup. The properties of the cancer and the treatment have to match for them to work cohesively. The next piece and a very great treatment option is radiation. So I will briefly cover what type of radiation treatments there are. There are a few different kinds, and then we'll focus on just one for the brain. There's what we call the external beam. This is basically radiation given from outside of the body. It's penetrated into the patient. Then there's a component that we call internal. This is given in very few types of cancers, with breast cancer or prostate cancer being two examples, where with the help of a catheter, there's a radioactive source that's placed at the center of the cancer. That radioactive source then continues to emit small radioactive material into the cancer with the hopes that it will destroy it. And lastly, there's systemic. This is primarily, it's actually very rarely given, but it is just similarly a radioactive source is injected into the patient, and that hopefully finds its target, generally given for thyroid, and acts very similarly in destroying the cancer. So what do we do for the brain? Well, in brain, we have a few different options. And these are primarily externally based. There is no internal or systemic source of radiation that we like using for the brain. Starting with the left, what we call whole brain radiation. Now, whole brain radiation basically means radiating the entire brain. And we do not like this option just because of the long-term consequences it has. It will lead to debilitating symptoms in a patient in the long term, primarily affecting their cognition and affecting their quality of life down the line. However, many times patients will present with many, many lesions in the brain, 5, 10, 15, where we cannot go and target each lesion. And generally at that point, the thought is there will be some microscopic cells left behind, even if we target each lesion. So the best option may be to go ahead and irradiate the entire brain. Next option that we generally use is not traditional. I will skip over traditional and go to stereotactic. We do not use traditional. As you can see, there is a wide range, even though the target is very small, there's a wide range of where the radiation spreads. It's just not an option that's used now that we have the last option, which is stereotactic radiosurgery. So what is stereotactic radiation? This is an example of one, which is using gamma rays. So basically, the brain is mapped out, the patient is put in a helmet, you do a CT scanning, the area is mapped out, and now very precisely radiation is given to target just the tumor, where we're preventing the radiation from going into the healthy tissue around it, and thus preventing the complications that may come with it by us affecting the healthy tissue. Now, pivoting to clinical trials. Clinical trials is another option and is certainly a very promising option. So what exactly does it mean to become part of a clinical trial? Well, a clinical trial is basically a research study where volunteers agree to test a new medicine. The trial is designed to discover whether this new medicine works and if it is safe. And it's only through clinical trials and the help of volunteers that important questions about new medicine can be answered. I want to thank you, Dr. Rachel Messia here for allowing me to borrow this slide. So what is the journey in terms of getting to the formation of new medication? Well, the journey is quite rigorous and it takes a very, very long time. We're talking years and decades generally. Prior to us even starting the clinical trials phase, the work that Dr. Garcia does is very important because that's what we call the preclinical trial, where the lab work is done behind the scenes, develop of the medicine, tested in animals and in human tissue that's taken out of humans. Once it's deemed to be effective in the lab realm, it is then starting to get tested in humans. And we start with phase 1. Phase 1, as you can see, has very few volunteers because, it's the starting phase, and this is generally testing for safety. Phase 1, we generally look for, is it safe to be used in humans? Further up is phase 2, which is starting to introduce a few more people into the testing phase. And phase 2 continues to test safety, but now we're also starting to ask the question, well, is the drug doing what we are hoping that it does? Is there efficacy of the drug against the cancer? Is it fighting the cancer cells as we had hoped it would? The next step then is, if the step 1 and 2 have passed, is phase 3. Now, phase 3 is just primarily comparing the current standard of treatment to the new drug. In addition, it's continuing to look at the same things as phase 1 and phase 2, still asking those safety and efficacy questions of the drug. Once we've passed phase 3, generally, this is a time where the FDA allows for the drug to be distributed to the public based on the efficacy and safety. So now the drug has become approved. And once the drug is being prescribed to the public, now we're in phase 4. We're still continuing to collect data on safety and effectiveness. And if at any point safety is questioned, the drug will be pulled off the market, off the shelves. And we've seen that over time with certain types of medications, where even though the drug was approved, a few years later, we noticed, hey, it's not doing what it's supposed to, or hey, it's causing a lot more side effects than we anticipated it to. So that's in brief how going from bench to clinical trials, how these drugs are introduced into the market. So who is eligible to partake in these clinical trials? So a lot of times we will talk to patients about exclusion inclusion criteria, and I will have to just find this in great detail so the patient understands. So just to briefly cover it here, exclusion basically means for some reason the patient is not able to partake in the clinical trial. Generally, this means there might be a rigorous age cutoff, and the rigorous age cutoff might be 18 to 70. And if the patient falls below 18 or is older than 70, they might not be able to partake in the trial, even though they might fit all the other criteria. Inclusion criteria means that you have something that makes you, that basically is the reason you should partake in the trial. For example, you have the cancer that the medication is formed for. So if you have the particular cancer diagnosis, or say we're testing this particular cancer treatment in patients who were smokers for a long time, and you have that smoking history, then you fit that inclusion criteria for that clinical trial. Here, there's many that are highlighted: demographics, lifestyle, such as smoking, like I mentioned, certain gender-specific conditions, breast cancer or ovarian cancer, where you need to be female. Of course, males will not fall into that category, although not for breast cancer, but only for ovarian cancer. Certain interventions, if you've been on recent certain medications, or if you have certain devices in place, you might not be able to partake in certain trials, only because it will not allow us to definitively say, was it the treatment or something else that allowed for the end result? Similarly with medical conditions, and also, of course, if you can allow for lab testing and so forth. All right, so in summary, I know I've covered a lot, but I wanted to mention here what we briefly talked about. So preventative. Preventive medicine basically means, are we screening? Can we screen early, and can we prevent this disease from occurring? And it is practiced in oncology, and it's done by early screening. It is harder to prevent brain cancer because of its rarity. In terms of treatments, brain mets is generally treated with surgery, radiation, and therapies. The blood-brain barrier doesn't allow for penetration of many of these therapies, so it makes it much harder for us to treat brain cancer. However, again, we're starting to come around this by the use of ultrasound induced basically vibration that allows for that penetration. Again, not all treatments are made equal. The treatment that may work on lung cancer will not or may not work on breast cancer or colon cancer, so forth. The properties have to match. And of course, at the end, clinical trials are always another great option. And I believe that is my last slide. Thank you so much for your taking the time to participate.